all your students who are FNBs and ENB students. And the topic that has been allotted to me by Sunita is cardiac hemodynamics and oximetry in congenital heart disease. So, I mean, this is something which is not just important because you do it, it is also important for our understanding of the congenital heart disease to a great extent, because there are lots of hemodynamics that happen, and in each case you'll have different kind of hemodynamics as well as oximetry depending upon the underlying anatomy. So it's good to know about it even if you are not going to practice it much in future. Okay, so what are the basics of cardiac catheterization? Number one, that we should ensure that the child or the patient that you're catheterizing is in a steady state. That means the patient is not crying, patient is not depressed or sedated. Both ways it is bad. Also, wherever we go, we must check where the catheter is coursing, and that is important because in congenital heart you can always have different connections and advexual lesions especially. So you need to know that where the catheter is going, and wherever the catheter goes, it is important to see the pressure as well as take a sample for oximetry as much it goes in time as possible, and for that reason measurements made during withdrawal of catheters are definitely superior to the measurements made during ingoing. That means if you are getting from right atrium, right ventricle to pulmonary artery, then you must make measurements of oximetry as well as pressures while you are withdrawing the catheter from pulmonary artery to right ventricle to right atrium, because you're going to do that in quick succession, and therefore it is going to be much more reliable. Also, if you want to localize the site of obstruction, for example, in infundibular and pulmonary and valvular pulmonary stenosis, use an end-hole catheter. There's not much point of talking about subaortic obstruction in patients when you're using a pigtail catheter, because pigtail has several holes. So we must use end-hole catheters. And before you do any angiogram, it is good to get all the data, because we must remember that the dye that we're using or the contrast agent that we're using would also have some impact on the hemodynamics. Some of them are myocardial depressants, and therefore your data may not be very correct if you do angios in between. So try and get all your hemodynamic data before you start putting dye into the chambers. Now, what is the kind of data that we collect? We try and get the oxygen consumption. That is very, very important, because as you would see, all your values of pulmonary blood flow, systemic blood flow have oxygen consumption on the numerator. But very often we are not able to do it, and therefore we use so-called assumed values, which are basically taking values from the charts available for different age groups and for different weight of the children. We also measure the pressure. For example, we measure the pressure on the right side, right atrium, right ventricle, pulmonary artery wedge. We for vessels, we, for example, aorta and pulmonary artery, we have systolic pressure. We have for ventricles, we have systolic pressure and diastolic pressure. Then also, of course, whatever other abnormal chambers you might be entering, you should try and take the pressures there also. And whichever chambers you enter, as I said, you must take oxygen saturation, and oxygen content is derived from oxygen saturation. And I will talk about it a little later about this in detail. Now, what are the calculations that we make? Cardiac index, especially in patients who don't have a shunt. But those who have a shunt, we talk about pulmonary blood flow or QP, systemic blood flow or QS, and then there is something called effective pulmonary blood flow or QEP. And this becomes important in cases where you have right to left shunt, for example, in tetralogy of Fallot. Then we also calculate pulmonary vascular resistance and systemic vascular resistance. Now, vascular resistances are very, very important because we are talking of large VSDs, large PDAs, and other shunt lesions. In some cases, for example, mitral stenosis, aortic stenosis, you may have to calculate valve areas, and that depends a lot on the cardiac index as well as pressure gradient. Now, it is important for us to express these values as per meter body surface area. It is important because for a child, 3 liter may be too much. 3 liter cardiac index may be too much, whereas for a person who's got a body surface area of 2 or 2.5, 3 liters is nothing. So we always standardize calculation for body size, and that's why we talk of cardiac index and not cardiac output. What is cardiac index? It's cardiac output divided by body surface area. And as I told you in an example, that for a 0.5 body surface area that you might have for a 4-year-old, 1.5 liter per minute is actually 3 liters. Whereas for a 50-year-old, if the body surface area is 2, then it is 6 liters per minute. That will be equivalent to 3. So you must try and correct it based on the body surface area. And as I said, you can take, you can use these so-called available charts for body surface area, which are derived from height, as well as some of them are derived on weight also. And you can always get the body surface area and then make your adjustments in your calculation. Normal cardiac index is 2.4 to 4.4 liters per minute per meter square. So index means per meter square. Whether you are using cardiac index, pulmonary index, or systemic vascular resistance index. And in a normal person with no shunt, cardiac index is same as systemic flow and it is same as pulmonary flow. Now, you must have come across oxygen content, oxygen capacity, oxygen saturation. So this is how you define oxygen capacity is the maximum amount of oxygen which is bound to hemoglobin, and you can actually calculate it depending upon the saturation and the hemoglobin. Oxygen content is the amount of oxygen which is present in the blood, and remember, oxygen content is a sum of oxygen which is bound to hemoglobin and also oxygen which is dissolved in the plasma. And this dissolved oxygen will become important if you are doing an oxygen study. In a room air patient, it may not be very important, and again we will talk about it as we go ahead. Then oxygen saturation is the percentage of oxygen which is bound to oxygen, percentage of hemoglobin bound to oxygen, and this again should be calculated as content minus dissolved divided by capacity. Now, oxygen content, something that you use for calculation of pulmonary blood flow and cardiac index also, is hemoglobin into 10 into 1.36 into oxygen saturation, and dissolved oxygen per liter is taken as partial pressure of oxygen into 0.03. So remember that oxygen content is bound oxygen as well as dissolved oxygen, and again, as I said, it may not be important room air, but when it comes to oxygen study, when you are using an FiO2 of 1 or 100% oxygen, then you can introduce as much as 20% of error by ignoring dissolved oxygen, and I will show you, I will prove this with an example. You have a hemoglobin of 11.8, you are giving oxygen to the patient with an FiO2 of 0.80, arterial PO2 is 300 and saturation is 98%. Now if you just calculate oxygen content by hemoglobin formula, then 11.5 into 10 into 1.36 into 0.98, which is the oxygen saturation, comes to 153 ml per liter. But if you take into account dissolved oxygen, which is 300 ml millimeters of mercury, then you have to multiply 300 into 0.03, that means 9. So actual content of this patient is 162.2 and not 153.3 as we thought. So you can see that if somebody can achieve a very high arterial CO2, then his oxygen content also goes up. And this becomes important because if you are calculating pulmonary blood flow or systemic blood flow, then you have to account for it, because if you remember, and I will show you the formula, these values of content go on the denominator. Also, it is important to understand that anemia can also make changes in oxygen content, and here is again an example long. It's an old data that you might come across, where you will see that for a hemoglobin of 10 compared to a hemoglobin of 15, the oxygen content can vary from 0.68 to 1. Similarly, if the oxygen saturation is increased by 20%, then they look at the values at 10 and then the values at 50. They're almost double. So it is important to catheterize a patient with a good hemoglobin of at least 10 or even 12 grams %. If you catheterize somebody in anemia, then you're going to get different values, which may not be correct. So this is how an RA pressure wave looks like. You have A wave, you have C wave, and you have a systolic wave, which is B wave. And in the right ventricle, you have a systolic pressure and an early diastolic, which is almost 0, and an end diastolic. So in ventricles, we talk of end diastolic pressures and systolic pressure. In pulmonary artery and aorta, we talk of systolic pressure, diastolic pressure, and a mean pressure. And you all know that pulmonary artery blood pressure is nothing. It is reflective of a left atrial pressure, because very often we are not able to enter left atrium. Similarly, these are left-sided pressures. If you can enter left atrium, it will be very similar to what you get as a pulmonary artery wedge pressure. Left ventricular systolic pressure, left ventricular early diastolic pressure, and if you want to take end diastolic pressure, you must reduce the gain so that your end diastolic points are well seen. Aortic pressure, same as pulmonary artery, in terms of systole and diastole, of course, much higher than pulmonary artery pressure. And we also like to take withdrawals from pulmonary artery to right ventricle on the right side and from left ventricle to aorta on the left side to complete our assessment. Another error, another source of error that may come up is if you are not very careful about the transducer position when you are measuring the pressure. You must have the transducer at the mid-chest level. Any change in the position of transducer will change your pressure. So if, for example, if you keep it above the left atrium is considered as the mid-chest position, then you can decrease the pressure by 0.73 millimeters of mercury. If you keep it below the left atrium, then you can increase the pressure. So it's good to keep you must check your pressure transducer is at the mid-chest level of the patient. This is how the normal hemodynamics are. If you catheterize somebody who's normal, you've got a SVC saturation which is good, about 70%. You have absolutely no step up or a step up of 5% or so. And then you have fully saturated blood on the left side of the system, LV, aorta, left atrium and pulmonary vein. Pulmonary artery wedge is also fully saturated. Here are the pressures. As you would see that the mean RA pressure is about maximum of 6, mean LA pressure is maximum of 8 or 10, and these are systolic pressures in the right ventricle which are same as that of pulmonary artery, and these are systolic pressures in the left ventricle. The end diastolic pressures up to 5 or 10 on the right side and up to 12 on the left side are acceptable. Normal cardiac index is 2.4 to 4.4. Now, whenever you are catheterizing a patient, the first saturation that you take would be a superior vena cava saturation. And we very often think that superior vena cava saturation is only for seeing a step up from SVC to PA. But it is important to see what the saturation is. If you have an SVC saturation of 70 to 80%, that is within normal limits and patient is good. But sometimes you can get very low SVC saturation, and these low SVC saturations, especially when you are catheterizing a sick patient or a very blue patient with an FA saturation of 60% or 65%, then if you get such a low SVC saturation, you need to be careful. You need to be sure that the patient is doing well, patient is not sedated, patient's cardiac output is okay, because very often these patients will be sick and they will have little cardiac reserve, and you're going to do angiography on top of that, and that might actually make the patient sicker. And that is why it is important in the cath lab to be sure that the patient can tolerate the procedure, because very often you can get into trouble if you are not careful, and the catheterization can actually result in a lot of complications, some of these patients. So if you get low SVC saturation, assess for the adequacy of ventilation. Many of these children may be very sedated, and that's why you're getting this kind of a saturation. See that they are well hydrated, and also sometimes it's good to check their ABGs or arterial blood gases to know if there is any acidosis. Now, once you've got pressure data based on whichever chambers you have gone, how do you link these pressure data? And this is important because very often in the exam you will be shown, like a pressure-based form with oximetry, and you will be asked to make a diagnosis. What is important is that you must link pressure. First of all, see if these absolute pressures are normal or abnormal. I showed you a range of normal. Then try and link these pressures to the next in line. For example, right atrial pressure should be linked with right ventricular and diastolic pressure. If you have a gradient over here, we are talking of tricuspid stenosis. The RV systolic pressure should be linked with PA systolic pressure, because in pulmonary stenosis there will be a gradient. Then the PA diastolic pressure should be linked with pulmonary artery bed pressure. Remember, if PA diastolic pressure is less than pulmonary artery bed pressure, the blood will not flow. So it is always more or equal to pulmonary artery bed pressure. Then you link the pulmonary artery bed pressure to left ventricular and diastolic pressure, and finally left ventricular systolic pressure to aortic pressure. Also, you should try and see what is the pressure between right ventricle and left ventricle, because very often you are dealing with a patient with CHD, whether it is restrictive or not. What is the relationship between pulmonary artery and aorta, and then what is the relationship between right atrium and left atrium or pulmonary artery wedge, because in large ASDs these tend to equalize. So right atrium and pulmonary artery wedge, and RV and LV. That is another thing that you must see when you are given a pressure data. These are values for calling any gradient as abnormal. For mitral valve, any end diastolic gradient is abnormal, but a mean diastolic gradient up to 5 you can sometimes get, especially when there is a large flow across mitral valve, like in ventricular septal defect, mitral catheterization. Tricuspid valve, end diastolic pressure of 2 or more is abnormal, up to 1.9 is normal. Again, mean diastolic gradient of 5 or more is abnormal. For pulmonary and aortic, we take a gradient of about 25 as mild aortic stenosis or pulmonary stenosis. But for peripheral vessels, whether it is pulmonary artery or coarctation, a gradient of 20 is taken as a cutoff of abnormal gradient. So this is what you need to remember, that across the AV valves, smaller gradients are important, and across the other semilunar valves and across vessels, higher gradients are important. Also, you will be asked whether this patient has mild pulmonary artery hypertension, moderate pulmonary artery hypertension, severe pulmonary artery hypertension. What is the value we use? In older patients or in adults, this is what we use. That mean pressure of 20 to 30, 31 to 49, and 50 and above for severe. But remember, in children we cannot use these values, because in children their pressures in general are lower, and therefore we try and express it as a percentage of systemic blood pressure. That means whatever is the aortic pressure, we compare it with that. Anything more than 66% of aortic pressure, we should call it severe pulmonary artery hypertension, even if it is not 50 and above mean pressure. It could be less than 50 because it depends on the aortic pressure. Similarly, the other thing that we classify is pulmonary venous hypertension. That means pulmonary capillary wedge pressure. Up to 12 is normal, 13 to 19 is mild, and 25 and above is severe. Some people like to call it, range of pulmonary edema. How do we diagnose shunt lesions? You have to have a step up at atrial level, ventricular level, or great artery level. But again, if you are taking only one set, then you obviously use much higher concentrations or much higher step-ups. But if you are using more than one set, then you can take a mean of those values. Again, these are very, very old data, as you will see, and these have not been really validated of late. And we really don't, bother so much. But what we do is we calculate QP, QS, depending upon the total step-up from mixed venous, that is SVC, to pulmonary artery. And that is how you calculate QPKS, and I will show you that also. Similarly, step down of more than 2% or an aortic saturation of less than 92% is suggestive of right to left shunt, provided you have ruled out other respiratory mechanisms for this desaturation. So how do we get left to right shunt? In what conditions? The classical example is atrial septal defect, but you can also get step up in pulmonary, in partial anomalous pulmonary venous connection, left ventricle to right atrial shunt, PSD with TR, RSOV to RA, coronary fistula to RA. These are, something that you need to remember, but very often the examiners are very fond of asking, enumerate the causes of left to right shunt at the atrial level, enumerate the causes of left to right shunt at the ventricular level, and then of course at the great artery level, the commonest being ASD, VSD, and PDA, but then there are several other conditions that can be to step up at various levels. What about right to left shunt? It could be from pulmonary venous desaturation, primarily because of sedation, hypoventilation, or sometimes because of pulmonary fistula or lung disease, and pulmonary edema. For example, if you have a patient with mitral stenosis, that patient may be desaturated because of pulmonary edema, but all this desaturation really responds very well to oxygen. Or it could be desaturation at left atrial level because of Epstein's anomaly, right to left shunt at the atrial level, intracuspid atresia, severe pulmonary stenosis with tricuspid regurgitation, and so on. Remember, a large ESD by itself can also give you a little bit of desaturation even without pulmonary arterial hypertension. Then at aorta and LV level, Eisenmenger is the classical example, and of course, tetralogy of Fallows can give you desaturation at that level. And in descending aortic level, if you get desaturation, think about Eisenmenger's PDA or PDA with coarctation or interruption of aortic arch, because it is feeding the lower half of the body. This is what we talk about: systemic blood flow, pulmonary blood flow, etc., etc. And I'm sure you all know the calculation, how to calculate, but you should also try and calculate QEP or effective pulmonary blood flow if you get desaturation in the aorta, like in tetralogy of Fallows. And normally, as I said, QS, QP, QEP, cardiac index, they are all same. But when there is a shunt, these are different. This is the calculation that I think you are all aware of, the formula. Cardiac index, oxygen consumption of pulmonary vein minus pulmonary artery. For QP, use pulmonary vein minus pulmonary artery. For QS, use aortic content minus mixed venous content, which you can either take from superior vena cava. Some people like to take 3 SVC plus 1 IVC, but most of us just use SVC as the mixed venous content. And QEP, which is effective pulmonary blood flow, is oxygen consumption of pulmonary vein minus mixed venous oxygen content. If you don't have pulmonary vein, assume it as 98% because we expect that they have normal respiratory system. So QP is calculated in cases with dissolved oxygen. If supposing you are doing an oxygen study, then you have to use dissolved oxygen, and therefore you have to account for the dissolved oxygen by multiplying 0.03 to pulmonary vein partial pressure of oxygen. Similarly, you do it for pulmonary artery, you do it for aorta, and you do it for SVC. So basically, you require CO2 values for all these 4 samples to calculate the real QP and QS. And if you see carefully, then if you do not account for these, then what's going to happen? QP is going to be falsely high because it is in the denominator. Similarly, QS is going to be falsely high. And therefore, if QP is falsely high, and if you are calculating PVR, then QP will, false high QP will give lower PVR because QP is in the denominator. So, if you do not account for dissolved oxygen, then you are going to get a higher QP and a lower PVR. And this is important, especially if you are thinking about whether this patient is operable or not because of a large shunt. So, this is of course the same thing that I am repeating, but you can also calculate QP-KS ratio based on the saturation only, and I'll show you an example soon. If the QP/QS is less than 1.5:1, we say small shunt. If it is more than 2:1, we say a large left to right shunt. And of course, if there is QS is more than QP, then it is a right to left shunt. So in left to right shunt, QP will be higher than QS. In right to left shunt, QS will be higher than QP. And for simple left to right shunts, we say QP minus QS is the amount of shunt. You will be several times asked, not just QP/QS ratio, what is the amount of shunt going left to right? What is the amount of shunt going right to left? And if you have bidirectional shunt, then you have to use the formula of QP minus QEP for left to right and QS minus QEP for right to left shunt. Now here is an example. You have 68% saturation in superior vena cava. There is a large VSD and you have an 88% saturation in the pulmonary artery. So you have a 20% step up at the level of right ventricle. How do you calculate QP over Q? Very simple. 98% minus 68%, 98% minus 88%. So this gives you a ratio of 3:1. So even if you don't know what is the absolute QP, what is the absolute QS, by saturation itself you can at least know what is the ratio between the two. And this is how we do it all the time in the lab. Now coming to the resistances, pulmonary vascular resistance is pulmonary artery pressure minus chest pressure divided by cardiac output. And in case of left to right shunt, we use QP instead of cardiac output. So systemic vascular resistance is aorta minus right atrial pressure divided by cardiac output. If there is left to right shunt, we use QS for SVR. So PVR is PA pressure mean minus LA or PAH, whatever you have, divided by pulmonary blood flow or QP, and the normal PVR is 123 Wood units. SVR is aortic pressure minus RA pressure over systemic blood flow or QS, and normally 15 to 30. Remember that PVR will be unreliable if you have differential or stenotic pulmonary arteries, and therefore that becomes very, very important in operability decisions. So, for example, in TAPVC, total anomalous pulmonary venous connection, PVR will not be of any use because they are not connected to the left atrium, pulmonary vein. So here is an example of a 2-year-old child, and you can see that there is a large VSD. Pressures are almost identical between right ventricle and left ventricle. There is a good step up from 74% to 87% in the pulmonary artery, and there is absolutely no desaturation in the aorta, 95%. QP/QS is 3:1, and because the pulmonary blood flow is coming out to be 8.8, pulmonary systemic blood flow is 2.8, and there is an almost normal systemic pulmonary vascularization despite severe pulmonary artery hypertension. This has happened because you have a high QP. So if you divide PA pressure minus PA wedge pressure divided by QP, your PVR is still high. So if you have a good step up, your PVR is going to be lower. But if you don't have very good step up and high pressure, then PVR is going to be high. Here we really don't need an oxygen study or test for reversibility because PVRI is already within operable limits in this patient. But many a times PVRI comes out to be high, and if it is so, then you have to check for reversibility, and that is in fact several times one of the reasons for catheterizing these patients, because you have large VSD, you can see everything by echocardiography, you have an X-ray ECG, but you are not very sure whether this patient is should get surgery done or not, or he is already Eisenmenger. And that is one good indication for catheterizing or diagnostic catheterization even today, because this kind of data you are not going to get by any other modality, whether it is echocardiography or radionuclide or MRI. PVR calculation is best reserved for cardiac catheterization only. So what you do, you can give any pulmonary vasodilator, but very often we use 100% oxygen. And we say that it is the response is favorable if there is a fall in diastolic and mean phase pressure. Systolic will not fall. If there is increase in pulmonary blood flow, and of course calculated PVRI will be accordingly lower. But again, I would say that you must consider dissolved oxygen whenever you are calculating in a patient who is being given 100% oxygen. Some people besides oxygen use inhaled nitric oxide, but then again, we are not going to really discuss that today. That's a separate topic in itself. So you have an aortic mean pressure, you have a PA mean pressure, and you can see there is a big difference between the two on oxygen. Even the diastolic pressures of pulmonary artery are much different than the diastolic pressure of aorta, but systolic pressures are quite identical, and that is a typical response in an operable patient if you give them 100% oxygen. Of course, you have to calculate PVR again on 100% oxygen. If PVR is more than 6 units, still I think it's a cause of concern. If PVR is more than 10 units per meter square, it is almost an inoperable patient. In some borderline cases, you may take other things into consideration like RP over RS ratio, patient clinical status, X-ray showing cardiomegaly or not. So, depending on that, you can take a call whether this patient should go for surgery or not. But again, even if you send them for surgery, we don't know what's going to happen to them over a long period of time, because these patients have severe pulmonary artery hypertension. They may not completely revert to normal PAH. So ideally, you take these patients to cath lab. The borderline cases, there is a clear operable group, there is a clear inoperable group. These patients are blue, these patients have cardiomegaly and everything, so you think they're operable. But then there is a group of patients where you're not sure. Let's say a 5 or 6-year-old child with large VSD, severe pulmonary artery hypertension, not much cardiomegaly on the X-ray, ECG also not showing much of, showing both right and left ventricular forces. Clinically also there's no flow murmur. So what do? You take them to the cath lab, you try and give them pulmonary vasodilators, and then try and define if these people can be divided back into operable and inoperable. Generally we would say if the PVRI is less than 5 or 6 units, then they are operable. But then many of these patients actually may not be so clearly differentiated even by cath. So there will be a smaller group which is still borderline, and in those cases, as I said, you have to go by clinical examination, by X-ray and ECG, before labeling that patient as operable or inoperable. So there will still be a small group even after cardiac cath where you are not sure. Coming to valve area, there are certain constants that have been described for mitral valve as well as aortic valve, and you can calculate valve area depending, there are various formulas, you must have heard of Gordon formula and so on. These are a simultaneous pressures of left ventricle and pulmonary artery wedge taken together, and as you would see that the pulmonary artery, the left ventricular end diastolic pressures is in fact little lower than where it is cutting the pulmonary artery wedge pressure. So there is no gradient, and this is what you normally get. But in a patient of mitral stenosis, you will see that the end diastolic pressure over here and the PA wedge over here, there is a big gradient in almost all the beats. This is pulmonary artery wedge and this is left ventricular end diastolic pressure. This is pulmonary artery wedge, this is end diastolic. So you have a significant gradient in all the traces between wedge and LVEDP, which is very classical of mitral stenosis. Here is an example of a patient who underwent PTMC because of mitral stenosis, underwent balloon dilatation, and you will see that what has happened, the gradients have kind of gone away. This is actually end diastolic is higher than the PA wedge. But look at the systolic waves. The V wave has become so tall, the PA wedge has become 40. So this is a patient who developed acute mitral regurgitation following mitral stenosis balloon dilatation. And this is important because many of the patients, when you dilate their mitral valve, they develop acute mitral regurgitation, and that makes the patient really sick. And that is very evident from just seeing the tall V waves following a balloon dilatation. So just about severe mitral regurgitation. This is another interesting case. This is a patient of 28-year-old lady who had history of rheumatic fever and is presenting in heart failure. Echo has shown a mitral valve area of 0.6 centimeters square. That means severe or very severe mitral stenosis. And if you see the hemodynamic data, you see absolutely no gradient across the mitral valve. This is end diastolic pressure, this is wedge. This is end diastolic pressure, this is wedge. Absolutely no gradient. In fact, if you see the LA and the wedge pressure, LA pressure and the LVEDP, there is no gradient. So patient has severe mitral stenosis but has no gradient. And this is simply happening because you have a large AST in this lady. You have a huge step of 53 to 90%, and that is what is producing heart failure in her because she has a large AST. So large AST can take away the transmitral gradient. You have to go back to echo to decide whether there is stenosis or not, because large AST can decompress the LA back into RA and therefore produce a large step up but takes away all the gradients. So you're going to miss a diagnosis of mitral stenosis otherwise. So cath data has its limitations. It has to be taken in supplementation. It has to be supplemented with clinical as well as echocardiographic data. So this was a patient of large AST with severe mitral stenosis. Now I'll also try and show you some more traces. This is a case of aortic stenosis. This is left ventricle and this is aortic ventricle. Now what I want to show you over here is that if you take peak to peak gradient, something that you actually measure at cardiac catheterization, 43 millimeters of mercury, peak of LV to peak of aorta. But if you take so-called instantaneous gradient, that means simultaneous gradient between LV and aorta, it is much more. And this is important to understand because what you measure on echo is actually an instantaneous gradient. What you measure on echo or on cath is a peak to peak gradient because you always take a withdrawal gradient. And therefore, echocardiography will always overestimate the aortic stenosis. So that is why you go a lot by mean gradient. Whenever you are assessing the severity of aortic stenosis, you don't talk of peak to peak or instantaneous, you talk of mean gradient. And as you know, these days even the indication for balloon dilation is based on mean gradient. Here is an example of subaortic obstruction. You have an LV which is almost 140 maybe, and you have again LV which is lower down, and there is no gradient between LV and aorta. But over here there is a gradient, and this gradient is because of hypertrophic or let's say because of subaortic obstruction. And what you have is a typical dome and spike pattern, or spike and dome pattern as is seen here. This is pretty classical of hypertrophic cardiomyopathy. So not only subaortic stenosis, you can also say that this subaortic stenosis is because of hypertrophic cardiomyopathy. Okay, another pressure trace. This is what is normal. You have a guiding catheter, and you can see that the guiding catheter has suddenly has started showing very low diastolic pressure, and this is called ventricularization, and this is dangerous. You should immediately take the guiding catheter. This is the problem in coronary artery disease when patients are going for angioplasty. They put in a guiding catheter in the coronary ostium, and if you get a pressure like this, that is a dangerous thing. That means it is against the wall. You should actually withdraw the catheter a little bit so that you see a normal trace like this. This is an example of a supravalvular aortic stenosis. You have left ventricle forces. This is into aorta. This is aorta because the diastolic pressure has not zero. So this is a vessel. So this is aorta, and then you have a severe gradient between this part, and this is actually supravalvular aortic stenosis patient. And supravalvular aortic stenosis will also give you a very high pulse pressure in the proximal part of aorta. Now this is another interesting case where you will see that there is a huge gradient between LV and aorta. LV is 250, aorta is 100, and then at some point the gradients have become much less. This is actually not aorta, this is left brachial artery, which is representative of aortic pressure, and the gradients have suddenly become much less. Why this has happened? Because patient had gone into sinus rhythm now. Patient was in junctional rhythm, and this is again very suggestive of hypertrophic cardiomyopathy, where atrial kick is very, very important. So if you have a rhythm which is not sinus, then the patient's cardiac output falls so much, the pressure falls, and you get a huge gradient. Once the patient achieves sinus rhythm, you can see the gradients are much better because the aortic pressure has recovered much more. This is again pretty classical of hypertrophic cardiomyopathy, that the gradient would be much better in sinus rhythm, and that is why many of these patients are actually given an AV sequential pacemaker to ensure that their gradients are less. This is a patient of pressure of right atrium, where you see a very high right atrial pressure, almost to the tune of 18 or so, and this is typically showing you a very deep X and Y wave, and this is called M pattern. This is classical of constrictive pericarditis. These are these are X and Y descents actually, but even the mean pressure is. What is important is that the mean pressure is also 18. Another patient where actually it is showing you large pericardial effusion or actually cardiac tamponade, and you can even see the variation with the respiration, which is like the pulse is paradoxical on the arterial side. This is a patient, in fact these are two different patients. This is left ventricle, this is right ventricle. What it is showing is that if the left ventricle pressure increases, the right ventricle decreases. If the left ventricle pressure decreases, the right ventricle pressure increases. This is called ventricular interdependence, which is not seen in this particular case. And therefore, to differentiate constrictive pericarditis from restrictive cardiomyopathy, you can use this while you are catheterizing the patient. You can see on a long strip when the patient is breathing whether these pressures are going in the same direction or these pressures are going in the opposite or a discordant manner. If they are discordant, then it is likely to be constrictive pericarditis. If they are concordant, then it is likely to be restrictive cardiomyopathy. So ventricular interdependence during respiration will differentiate between these two conditions. This is simple. You have main pulmonary artery, you have RV outflow tract. There is absolutely no gradient, but then you have a huge gradient from right ventricular outflow tract to right ventricular body or inflow, and that is very classical of infundibular stenosis. Again, remember, you should be using an end hole catheter for taking these gradients. Using a multiple hole catheter will not give you the site of gradient. This is classical of valvular pulmonary stenosis, that you have main pulmonary artery and all of a sudden you start getting gradient as soon as you get into RV, whether it is outflow or not. And again, this would suggest valvular pulmonary stenosis. Coarctation of aorta, of course, angiographically you can always pick up, but as I said, the gradient has to be more than 20 millimeters of mercury for calling it significant. And of course, you have a very high gradient over here. Look at the ascending aortic pressure, very high pulse pressure, and look at the descending thoracic aortic pressure. The diastolic are not very different. You will see that the diastolic are almost same. It is a systolic which has become very different, and this is actually looking like a damped trace or a damped tracing. This is classical of hypertrophic cardiomyopathy. We always talk about it as a broken burrow response, but what is it? Broken burrow response is that if you get an ectopic, then the next post-ectopic beat, the left ventricular pressure is more, the gradients are more, but more importantly, the pulse pressure is also reduced. See, if you compare this aortic pressure to this aortic pressure, the pulse pressure is reduced over here. This is what is classical of hypertrophic cardiomyopathy, because the left ventricle is now contracting with more vigor. But in a case of fixed subaortic stenosis, the pulse pressure doesn't get small in the post-extrasystolic beat. So there is an extrasystole over here. The gradients are the same, but more importantly, the pulse pressure hasn't changed, unlike patient with hypertrophic cardiomyopathy. So this is fixed aortic obstruction or subaortic membrane maybe. So this is another trace which shows you that this is the aortic pressure and this is left coronary artery pressure, and what it shows is again ventricularization. If you see something like this, it is highly suggestive of left main coronary artery disease. I know most of you will not be doing much of adult work, but then I think there will be time when many of our patients who have survived their childhood, their adulthood, would go on to develop coronary artery disease. Therefore, as a pediatric cardiologist, we need to know a little bit about coronary artery disease as well. And this is ventricularized pressure in the left coronary artery when you do injection with the left coronary artery catheter or Jetson's catheter, and this would be very suggestive of a left main coronary artery disease, something which is serious, and therefore you need to be very, very careful if you get that kind of a trace. This is during right coronary angiography. Not uncommon that the catheter just gets wedged into the right coronary artery and the trace looks really damp. And what is important is this is catheter deep throat in our case. So the diastole is very flat and there is a pretty systolic dip. So this would again mean that you have to withdraw the catheter, come out a little, because otherwise it might injure the coronary artery, especially if you make an injection. This is another interesting case that has, the diastolic pressure is higher than the systolic pressure. So you see two ways, but the diastolic pressure is higher than systolic pressure because this patient is on, see this is systole and this is diastole, because this patient is on an intra-aortic balloon pump. So whenever you have a patient on intra-aortic balloon pump, then the diastolic pressure becomes more than the systolic pressure. This is the only condition where diastolic pressure becomes higher than systolic pressure. So if you get that kind of a trace, please see it with the ECG and then take a call which is higher, is it diastolic pressure or is it systolic. Now I'll show you some of these hemodynamics as well as oximetry data which are often shown in the exam for you to decide how to analyze. So you have an 18-year-old asymptomatic patient whose is cyanotic, S2 is widespread, and there is a good detection systolic number. The first diagnosis that comes to our mind is atrial septal defect. Right? Now, is it atrial septal defect or not? What would you see? There is a good step up from right SVC to right atrium. But what is wrong is that your left atrial pressure and the right atrial pressure or the wedge pressure are very different. If it was a large ASD, then these pressures should have equalized. So the ASD cannot be large, ASD is going to be small, but then you have a good step up of about 13%. So this was a case of partial anomalous pulmonary venous connection, which was giving you a good step up, but it wasn't equalizing the right atrium left atrial pressure because ASD was either not there or it was very restricted. It will give you almost the same finding at the bedside. Another example is a 12-year-old patient who was diagnosed to have atrial septal defect, but I think the odd thing over here is that femoral artery saturation is low. So once the femoral artery saturation is low, you have to think of a reason. It could be a very large ASD like common atrium, as I told you before. Sometimes that can give you, a little bit of cyanosis. But what is important over here is equalization of saturation. So if you look at the right atrial saturation, right ventricle, pulmonary artery, left atrial, they're all within the range of 87 to 89, which is highly suggestive of total anomalous pulmonary venous connection. Why supracardiac? Because superior vena cava itself is also very much desaturated. Also remember that the PA pressures are almost normal or mildly elevated, therefore it is not going to be obstructive. It is going to be unobstructive supracardiac total anomalous pulmonary venous connection at this age. At 12 years you would mostly have unobstructed. But what was not picked up was a little bit of cyanosis because the saturation was so good that it was not picked up at the bedside. This is a 23-year-old fellow where we know he has a large VSD pulmonary artery hypertension. We were studying him simply to decide whether he is operable or not because he's 23-year-old and he may not be operable. He was pretty sick. He had severe mitral regurgitation and he also had atrial fibrillation. And then of course there is a step up at the RA level from 41 to AD7 and you have a huge step up actually, and therefore your QP is very high and your PVRI is coming quite normal, and therefore this patient seems perfectly fine and operable. What is bothering me over here and what should bother you is look at the SE schedule. It's so low, just 41%. This just tells you that the fellow is pretty sick, and look at his pressure. He's just 90 systolic pressure or 90 LV pressure. So obviously this patient is very sick, and if you load him with dye after doing all this hemodynamic study, if you load him with dye for doing an angiogram, he's definitely going to get worse. So it is important to see what is going on at the time of cardiac catheterization, then just ignoring it completely and going ahead with the protocol. In this patient, once we saw all this, we actually did not do any angiography because the diagnosis of VSD was there by echocardiography. What we were studying in was more for deciding the operability. But in view of such low saturation, we decided not to go ahead with angiography in this particular patient. This is a 3-year-old, diagnosed as tetralogy of Fallot. Everything looks fine. There is desaturation in the femoral artery. LA is fully saturated. All these saturations are also quite low. But what is odd is that your right ventricular pressure and left ventricular pressures are not identical, which they should be in a large VSD of tetralogy of Fallot. So what is happening over here? We have a tetralogy where the VSD is getting restricted because of either tricuspid tissue or an aneurysmal tissue, whatever it is, but this physiology doesn't go with tetralogy. Another 3-year-old, cyanotic since birth, and I think the odd thing over here is if you look at the saturation, he is desaturated, so he is cyanotic, but then his CA saturation is higher than the aortic saturation, which is again highly suggestive of transposition of great arteries, and if you diagnose that, then you will see that his CA is connected to left ventricle and his aorta is supported by right ventricle, and that again confirms that this patient has TGA. Of course, he has no VSD because his LV and RV pressures are very different. So he is not only TGA, you can also say that he has intact ventricular septum, and because his saturations are not so bad, because he is a 3-year-old, survived to 3 years, he has to have an ASD. So he has an ASD also. This is a 16-year-old with a large VSD, severe pulmonary artery hypertension, plus minus operable. Took him for catheterization, and you will see that there is a step up of 65 to 78, 13%, and there is very little desaturation of 93%. LV is 95%. Pressures are very high, systemic. RV pressure, PA pressure are same as LV pressure and FA pressure. We give him oxygen for 10 minutes to test for operability, and we get even a better step of 20% over here, and fully saturated, almost fully saturated femoral artery, and we achieve a very good POT of femoral artery as well as well. Okay, we do the calculation. This is what we get. In Room-Air, his PVR is 15.8, his PVR-SVR ratio is 0.6, so by all means he is inoperable, but on 10 minutes of oxygen he reverses. His PVR falls to 6.4 and the ratio becomes 0.22, so by all means he becomes operable. But then the mistake we have done is that we did not account for dissolved oxygen. The moment you account for dissolved oxygen, his QP falls. It falls from 10.7 to 6.8, and therefore the PVRI rises to 10 units. And now we know that a 16-year-old fellow with such severe pressure is actually inoperable. So he was not offered surgery because his PVRI was very high, and I think he falls into a range of Eisenmenger, almost Eisenmenger syndrome. So having talked about cardiac catheterization, hemodynamics, what are the sources of error? Something that you should be aware of, because catheterization and angiography is considered the gold standard, and therefore any error in doing cardiac catheterization must be noticed, because otherwise we are going to make wrong judgment for that particular patient's management. So error in pressure recording, I told you about the transistor level, about the lines, whether they are under or over damped, wedging of catheter, use of multi-hole catheter for withdrawal gradients and to know the site of gradient, for example, using a multipulsar or a pixel catheter. Then there are errors in oximetry. If you are when you are withdrawing the samples, you must ensure that there is no air into the syringe, there is no saline into the syringe. Also, you should not let the sample lie down for a long time, because that can also increase his oxygen, the sample's oxygen content and oxygen saturation. Another thing that we often do is that we use the same machine that we use for ABG sampling to decide what the oxygen saturations are. It is better to use a co-oximeter, which is a different kind of an equipment, because that will give you the oxygen saturation much more reliable than ABG, where the oxygen saturation is actually derived from PO2 values. Then of course we are assuming oxygen consumption in all these calculations. We are assuming pulmonary vein saturation many a times. We may not be correcting flows, because we are not using the body surface area, and we must remember that flows need to be corrected by dividing instead of multiplying, and also failure to account for dissolved oxygen when we are doing a pulmonary vasodilator study. Also, measurements made during unstable hemodynamics due to arrhythmias, acidosis, hyperventilation, etc. are going to give you false values of pressures as well as saturation. So, what are the take-home messages from this? Oximetry pressure data must be clearly recorded and systematically interpreted in the light of presumptive diagnosis. You have to have a diagnosis before you proceed with catheterization. In fact, you should have a plan as to how you're going to cath this patient, what catheters are you going to use. The data has to be internally consistent. If not, then please repeat. If there is an unexpected find, you should verify by repeating the measurement. And another important thing that I've seen with residents specifically is that if something is not fitting, then you say, all right, you will ignore it. You will say this is not correct. That is not a right approach. You should never ignore any part of the data. Maybe you do not know how to interpret it. Maybe somebody else can interpret it for you. So you should never ignore any part of the data, whether it's pressure or oxygen, right? Okay. So now I think I will invite any questions that you may have. We always need oximetry. Basal PVRI is more than 10 good units. Are you asking that do we need an oxygen study? Basal PVRI is more than 10 units. Is that the question? Yes. Okay. So if basal PVRI is more than 10, I think we should still do oximetry, especially if clinically you should do oxygen study, especially if clinically you feel that the patient might be operable. Obviously, you've taken the patient to cath lab simply to know whether the patient is operable or not. If the patient was clearly inoperable, you would not be catheterizing that patient. If you have decided to catheterize this patient, obviously this patient is someone where you still feel that there may be some amount of operability, and therefore once you are there, once you are in the lab, it is always good to do an oxygen study rather than come out and then repent later. Of course, you may get a data where your PVRI is still high, more than 8 units or more than 9 units. You will not send for surgery, but at least you will have that hard data with you to take that call. Because telling somebody that you do not require surgery and there is nothing I can do for you is also something that you need to do with lot of care, because you are really writing off that patient forever. Basically. Any other question?